Hello. Hello. Hi. Hello. Still two more, by the way. Two more. I won't say their names, but I suspect the internet connections are slower than most. Hello. Hola. How was that? That was good? Bon dia. How about that? What else? Marhaba. Ahla wa sahla. Namaste. Bonjour. I'm out. I'm done. Ni hao. Oh, I'm still thinking. I'm still thinking. I'm still thinking because today I'm having a odd morning, and it's an odd morning because my other half is not here today. It's RL nobody because Reza's with family. I still love him though, but I'm sad that he's not here. So we will make do with me only, but of course this is not a solo party. Yes, all our VMR. It's so true, Travis. If you have a case, please, please, please jump on in to present it. I cannot wait to nerd out with you all. And today we'll try to liven it up. Konnichiwa. That's right. Didn't know that. Is there an R in there, Kanu? I don't think there's an R. Is it? I don't know. Maybe. Who knows? Connor, do you have a case to present? I'm gonna pick on you. Who has a case to present? Somebody present a case in the meantime. Oh, two N's. That's right. I have a reflection. If you could see my screen now, it says all caps, not all caps, but it says Sharmeen Shikarchan. You know why? Because she was the last person to speak during the huddle before this. It says just a big, like, just her name. I hope you're seeing the same. If not, you should be, because Charmine, as you may know, recently took over the leadership of CP Solvers about a couple months ago. Now I see Kushal and his smiley face. And somebody, but you have no power to mute me, my friend. I will unmute whoever did that. Uncool. I will remain loud and boisterous because Charmine took over the leadership of the CP Solvers in the running of the CP Solvers a couple months ago and had the wisdom to grow us and shape us in many ways, many ways, including the wisdom to reach out to you all. So, we've been growing CP Solvers naturally and authentically and creating things like VMR, creating things creating things like WDX and the anti-racism series. All those were organic, we just grew over time. And no one thought, wait, like, what about the people who consume this? What do they want? And amongst many things that Charmine has been doing is the wisdom to actually help us bring on people to reflect on that and to reflect with you all on what makes CP Solvers tick for you. So through little to no effort on your end, we'd ask you to give us feedback right here on this form that I just copy pasted in the chat. Why are we doing this? We don't have to. We can keep doing what we're doing, but what we really care about is how you all consume the work that we have and how else we can optimize it to you, because we don't really care about anything else. We have no sponsors, no financial incentives, nothing. All we really care about is that you all are happy. And if you're happy, we're happy. And if I'm happy, then I eat my yogurt, which I finished because, again, I'm lonely without Reza today. You could also tell us, stop talking about Reza and Lobby's love affair in the feedback form as an example of the kind of feedback you could say. With that, I will beg and plead, please, please, please fill out the form. It took me 2.5 minutes to do it. And I cannot imagine that it would take you more than 5 minutes of your time. So even in the middle of the VMR, if you're like, oh my God, Robbie, stop talking, use that time to fill out the form. And Hans, thank you. Thank you for that very, very, very kind reflection. All right, y'all, who has a case? Anybody have a case? Are members invited to fill the form too? Let me see. If you are a member who is not Rafa, fill out the form. If you're Rafa, keep your opinions to yourself. We don't care. Oh, of course, fill it out. Please fill it out. Please, please. Everybody should fill it out. I filled it out. Everybody should fill it out. Yeah. Okay, who has a case? Who has a case? Anybody have a case? See, when Reza's not here, they're like, you know what? Screw it. We don't need a case. This is going to be boring anyway. Who has a case? Oh, no way. Really? One of my favorite people in the world has a case. Hello, Tiago.
So Hi, Rabbi.
Hello,
So
hello. Good morning.
I'm glad being here again. Good morning, good afternoon.
Good
So
afternoon.
I can try a case. I mean, I did not prepare it, but I have a case. It's endocrinology. So I try not to say I'm an endocrinologist, but every time I say something, you say, "Oh, keep in mind that he's an endocrinologist." Uh, but I can present a case here.
Wonderful. That'd be amazing. I'm going to try my very best to involve the crowd and land on a non-endocrinology diagnosis. So we'll see.
Okay.
Yeah,
So should I start?
let's rock and roll.
Okay. So it's a 51-year-old female that presented with coarse hair throughout the body.
Mhm.
Do you want me to talk more or is it enough?
Yeah, no, I think this is a little bit of data to reflect on. And maybe what I can do is to try to highlight the reflections in the chat. So Kanu's already thinking about hirsutism. Kanu, can you tell us a little bit more about that?
Hi everyone. So whenever I think of, am I audible?
Yes, you sound great.
Yeah. So whenever I think of like a female having hair all over her body, so I like to think of hirsutism. And if there are other secondary features, let's say hoarsening of voice, um, or other coarse features, then I also like to think of virilization, which is I think a very serious complaint to think about, because then I think about malignancies. Hirsutism, I think, can be a benign nature as well as of malignant nature. In benign diseases, I like to think of PCOS, polycystic ovarian syndrome. I like to think of probably a functioning pituitary, adrenal, or an ovarian tumor that may be causing that, or it could just be steroid abuse that could cause it. In malignancies, it could be a functioning adrenal malignancy or again an ovarian malignancy that are like more dangerous things. Apart from that, I think other steroid mimics or something like Cushing's, etc., can also cause hirsutism, and those should be kept in mind.
Brilliant. I have nothing to add to that reflection. And I think Travis is talking about adding more detail about PCOS. So Travis, can you tell us what you know about PCOS?
Oh man, put me on the spot.
Always,
So, yeah, you know,
always ready to.
just more or less from the ER standpoint, it's a good, I guess, physical exam finding you can see in someone who's coming in with, maybe lower abdominal pain or who has ovarian cysts, and kind of noticing, a physical exam finding of coarse facial hair. And, maybe the patient thinks it's normal because they've had it for a long time, just something, a question to ask the patient about, when kind of, looking at the exam, and specifically in patients who come in with ovarian cysts. I mean, that's kind of like the most common thing that I'm seeing with patients. So something to give them some insight about, and reflect on, to see if they've had that worked up, or if that's something that they've always had.
It's absolutely brilliant, and I love the emergent approach to this. And I think the other dimension to add on is to reflect on whether this is true pathology or not. And I think that across the globe, there are varying rates of what we describe as normal. And I think that's true of everything we do. There's varying levels of normal dietary consumption, normal weights, normal heights, normal lab parameters across genders, cultures, ethnicities. And I think the first key question here is this pattern actually within the expected profile of the patient's community and ethnic origin? But when somebody's presenting to care to discuss this, it's either as a result of the unfortunate effects of stigma on women and pressures to appear a certain way. Is that the reason the patient's seeking care? Or is the patient seeking care because of pathology that is reversible? One is reversible, and two may reflect complications outside the cosmetic, the socially imposed cosmetic dimension of this. And I think that's the first question to analyze is and I think Tiago talks about this a lot with endocrinology. And I remember he did this with gynecomastia, is do you actually need a workup? Is an alternative cause either, is it not gynecomastia at all? Or is an alternative cause readily apparent on your initial screening labs, like somebody who's jaundiced and has gynecomastia, for example? And I think that's the first key question here is this, do you need to work this up? And of course, the context, other patients, family members, other people, and then also the tempo and the other clues will help us prioritize that. So the first key question is this abnormal or not? And that will be understood by virtue of the time course, the accompanying features, and studying the patient's genetic and ethnic community. And after that, I think the spotlight is on whether there's an endogenous androgen in the form of, with the source being the adrenal glands or the gonads, or is this an exogenous androgen in the form of something that the patient might be exposed to? And for more, we'll pass the mic to Tiago to outline us more, but I'll tell you, I'm already really eager to learn from Tiago with his masterclass. I have a feeling this is going to be the Friday VMR that has 20 minutes of Tiago in it. So I will move speedily through the case and learn from him at the end.
Oh, it will not be, definitely. I learn a lot with you and the discussion is perfect. So she noticed excessive coarse hair growth and acne in the last years. And for this reason, she consulted her dermatologist last year and her gynecologist 4 months ago. So her last period was 4 years ago. The dermatologist prescribed her levothyroxine, and her gynecologist prescribed her a pill, cyproterone plus ethinyl estradiol, 4 months ago. And she confirmed that her voice had recently deepened after I questioned about it, because the voice was, I mean, as Rabbi said, it's a very sensitive point because it may be her voice, but it was deepened. And then I asked her, and she told me, yeah, it's changing recently. Do you want me to move on or stop here, Rabbi?
You know, I think why don't we just reflect on here? And I think Kanu is bringing up another great point about virilization. And I think that there's more and more evidence that this is pathologic. And that's immediately apparent that you need an evaluation, primarily because it's not just hirsutism. There are accompanying features that raise alarm bells. And one of those accompanying features, the presence of acne, and the abrupt onset, the presence of acne, and the voice deepening, all those are features that raise the spectrum for a secondary cause. And I think that the first evaluation would be to reflect on the presence of something exogenous, and then again start to wonder, what is the source of excess androgens? What I'd be really curious to know, and Tiago, you can feel free to keep this and just teach us at the end, or now I'll defer to you. I don't know whether this tells us that the androgen is testosterone based on the voice deepening, or whether we need to reflect on the possibility of an adrenal source. And that I don't know, but I will tell you that at my limited knowledge, I'm starting to, whether accurately or erroneously, start to worry that the source may be excess testosterone rather than adrenal, but I think I might have that wrong, and I'd have to look at that. But now I think at first we were like, do we need a workup? And I think now the answer is clear that we need a workup. And the workup is largely driven by conversation with the patient about exposure to androgen, and then a reflection on whether there's adrenal or gonadal source of androgens, with, I think, though I'm likely wrong, that the deepening of the voice might prioritize a gonadal source. That's where I'm at.
Okay, Robbie. So just a point regarding what you said. So adrenal gland, it produces testosterone because, you know, DHEA, androstenedione, and then testosterone. So you can have testosterone from adrenal gland. If you look to steroid genesis, you will see the picture. It's many steps, and then you can get through testosterone in the
awesome.
final product.
I love it. So essentially, we really cannot make any progress on the source of the androgen exposure based on the history. We have to study it by laboratory or imaging. Is that fair? Awesome. Beautiful. That's a great pro. Thank you so much. All right, why don't you give us more information?
Okay, so let me come back to the case here. So past medical history, hypothyroidism, hypertension, and type 2 diabetes. She lost approximately 20 kilograms in the last 3 years after being diagnosed with diabetes, and she attributes this weight loss to diet changes. Her medications are 25 micrograms of levothyroxine, losartan 50 milligrams daily, metformin 2 grams daily, Galvus 100 milligrams daily, and the contraceptive pill, Cyproteron plus etinoestradiol. Social history, nothing relevant, no allergies, and that's it for now.
Amazing. You know, I think that um, I'm just looking at the medications again. I'm reminding myself that a large fraction of hirsutism is from medication-induced hirsutism. And I remember this at a patient who was prescribed minoxidil for hypertension, who developed hirsutism. And so I'm looking closely at the medication list to see if there's anything of that nature, and I don't see that. So the other pertinent medical history is one endocrinopathy, and we know that one endocrinopathy portends risk, portends risk for other endocrinopathies, but the base rate of incidental hypothyroidism is so high that you cannot really use that practically as a leap to say that the person might be at risk of another endocrinopathy. Whenever somebody with type 2 diabetes, presumed type 2 diabetes of the usual type, loses weight, you have to celebrate that with the patient. And I think that's one great thing. But in some instances, it might portend a reflection on something a little bit more sinister. So whenever somebody is glycemic control or weight improves in patients with diabetes, I wonder whether they might have chronic kidney disease and the cachexia that follows chronic kidney disease, or whether they might have developed adrenal insufficiency. How can you link diabetes, weight loss, and abrupt onset hirsutism? There's a rare esoteric connection, but we can't move past rare esoteric connections in VMR. And there's this syndrome called an insulin receptor antibody syndrome, where patients usually with lupus and other autoimmune diseases develop an antibody to an insulin receptor. And those patients get alternating hyper and hypoglycemia along with marked hirsutism, acanthosis nigricans, and PCOS-like changes. So here, I'm like, patients with diabetes lost weight, high five. But in the development of hirsutism would prompt me to check for atopic acanthosis nigricans and start to wonder, amongst the many list of possibilities, again, adrenal, gonadal, or other, whether we have to sneak in insulin receptor antibody syndrome here. And the clues to that would be acanthosis nigricans in unusual places like the arms, and some abnormalities in their lipid profile, which will stop. I'm looking at the chat to see if there's any. Rafa, you're making some great comments on PCOS. Do you want to just unmute and tell us more?
Hi, everyone. I just wrote on chat the Rotterdam criteria for PCOS. So we have to have chronic anovulation, as this woman is not ovulating in 4 months. We have to have high testosterone, so we have to dosage the how do you say, the androgen, I don't know the exact hormone you have to dose, and you have to have cysts on US on ultrasound. So if you have 2 criteria, you can confirm this syndrome.
Beautiful. That is spot on, my dear friend. I think that PCOS, if you take all comers, let's just keep it simple again, because I think we're going down a very specific bucket here. But if you take hirsutism in all comers, in half of patients, you won't find a specific diagnosis, and half of them you'll label it to expected hair growth within that population. But if you take true pathologic hirsutism secondary to some conditions, PCOS accounts for the majority of them. The problem with PCOS is, in this case, is PCOS is a complicated diagnosis to make, but can be very easily ruled out in one circumstance. It's when it develops in older adults. The vast majority of patients with PCOS develop their symptoms as teenagers and actually slowly start to improve in their middle age years. So while PCOS begins as the most common cause of hirsutism, it plummets in probability in a patient who develops a syndrome in their late 40s, early 50s. But I think, Rafael, the point that you're making is it's actually very hard to make that diagnosis with confidence, and often is a working diagnosis based on the elevated testosterone and the ultrasound features. So the reason that we're like jumping past very common things is, again, 50% is idiopathic, and then another 50% is PCOS. Both of those things are unlikely because we found accompanying features and because of the patient's age. So we're in esoteria here. And I will say that one thing to recognize is our focus is going to be on examining the hair distribution in the patient, but the skin may offer a lot of clues here. If the skin has features of stria, you might have to wonder about Cushing's syndrome, which may be pituitary, but here you have to worry about adrenal cortical carcinoma. You may look for features that would suggest acromegaly in the form of the bony changes and the skin tags that patients have. And again, as we alluded to, you have to look for acanthosis nigricans in typical but also atypical spots. So what I'm really going to be listening to is the exam here is key. A lot of us are going to be inclined to look at the laboratory data, which of course will be much more informative and definitive than the exam. But this is the instance where you actually ask a patient to do a full skin exam, because you might see things that will skew the lab abnormalities and help you understand the lab abnormalities. And I will tell you, I do not examine every patient head to toe, but in this instance, I'm really curious to see what the skin exam, because I suspect the pathology will rise to the surface of the skin, not just in the form of the hair, but subtle skin findings. So I'm really curious what Tiago's skin exam will show us.
Yeah, great discussion. Just one remark, because I work with endocrinology. Many women, they come to the office saying that their ovaries, they have cysts. And I just say, that's what's expected. You expect your ovary to have cysts. So the Rotterdam criteria, which Rafael said perfectly, you need to, so what is the ultrasound criteria? An ovary with more than 10 centimeters cubic, or at least 12 cysts with 2 to 9 millimeters. So if you have cysts, it's not an ultrasound mark. So you have to fill those criteria. I think it's very important, because I see many patients, they say they have PCOS just because they have cysts in their ovaries, and they do not fulfill criteria even for ultrasound. And if you take Rotterdam, less. So I'll keep with the case, the physical exam. She did not have acanthosis nigricans. She did not have strias. She did not have had hump. She did not had moon face. Nothing was abnormal except her BMI of 36.7, and her blood pressure was 140/82, and her modified Fairman-Gallwey score was 15. And Fairman-Gallwey score, for you who are not used to use it, just take a Google. It's a score that you give for hair to differentiate between hypertrichosis, which is having hair in places where women have hair, from hirsutism. And it's considered abnormal once it's over 8. So this 15, it means that she has hirsutism, and it's not difficult to lead with this score. So if you just Google it, you'll see.
This is incredibly helpful. And I think that, the negative predictive value of the things we were looking for, right? Because we were looking for, is there evidence of excessive insulin resistance? And the answer is no. Is there evidence of Cushing's on the surface? And the answer is no. And I'd say the negative predictive value of these things is good, but not perfect. Like I would has a non-Cushingoid exam or a non-excessive insulin resistant exam ever stopped me from getting the test? No, but it really moves the needle away from those disease processes. And so what progress have we made? We're starting to zero in on testosterone, or the gonadal, androgen axis being the sole abnormality. Because before we're like, is this idiopathic? Is this related to PCOS? Both of those are less likely. Then we had a spectrum. Is there acromegaly involved? Is there insulin resistance involved? Is there concomitant hypercortisolism involved? And the answer seems to be less and less and less likely. So the spotlight is zeroing in on androgens alone being the sole abnormality. And with that, I'm starting to worry more about the possibility of a process that only produces androgen. And I would say I don't have a greatest grasp of this land, but know to worry most about adrenocortical carcinoma. And I've learned some very interesting and fun facts about adrenocortical carcinoma. Which is to say that it actually affects women more than men, and the epidemiological profile is unlike many cancers in that patients don't actually get it with older age. They get it kind of in their middle age, like this patient has. Because we think about lung, breast, the older you are, the more risk you are, but adrenocortical cancer has these funky features to it, a little bit more common in women than men, and predominates in middle age, not older adults. So again, if I were navigating this world, I would be navigating it without knowing exactly where to place my foot next. And I would be only know to go in the general right direction. What I'm noting is the lack of accompanying features of this syndrome, which has me prioritize adrenocortical carcinoma as the most kind of no misdiagnosis, but I wouldn't be surprised if there are subtleties of gonadal tumors that only produce testosterone. Going back to my step 1 days of Leydig and Sortelli tumors, but I think those are much less common than the most morbid consideration was adrenocortical carcinoma. But at the end of the day, I think we have to work everything up. We have to think about all those things, using the skin exam as a clue that they're less likely, but not using the skin exam as a definitive test when we have more sensitive tests available to us. All right, Tiago, back to you.
Great. So just comment one point that you said that I liked a lot. So the age, and you know, the age is generally between 50 and 60. The mean age is not good. Do you know why? It's because of the genetic syndromes, Liefeld-Man and Beckwith-Wiedemann. So there are many patients that they have adrenal cortical carcinoma with less than 10 years of age, very, very young. So if you take the mean, it will represent those children. Yeah. So two uncommon syndromes.
Epic. Tiago, I think you should comment after every aliquot. This is amazing. Thank you.
That's no, I'm sorry to comment. It's just because I like very much what you say, that it's amazing to remember that. Yeah, so the mean age is affected because we see children with adrenocortical carcinoma because of rare genetic syndromes.
Thank you.
So her exams, WBC 4.1, hemoglobin 12.3, platelets 381, sodium 144, potassium 4.1, calcium 9.1, creatinine 0.72, AST 29, ALT 41, fasting glucose 85, A1C 5.9, HDL 37, LDL 134, triglycerides 104, TSH 2.9, free T4 0.95, anti-TPO negative. Testosterone 373. So women normal is 15 to 70. SDHEA 152, and it changes with age and sex, and the normal for her would be 8 to 100 80/80.
Awesome. So Thiago, can you just tell us what the last test was? I think I think Chiara didn't quite catch the label. So it's DHEAS. Is that the adrenal androgen test or? Yeah.
Yeah, DHEAS. Sorry,
No, perfect.
we put the S first in Portuguese.
Oh,
Sorry.
really? How do you say it in
Yeah,
Portuguese?
in Portuguese would be SDHEA.
Amazing.
S. Yeah, it's the S.
The other way? That's cool. It's the right way in my opinion. English can wait after Portuguese. We prioritize English way too much in the medical world. I really, I got to tell you, I'll just summarize real quick where I'm at. I think the conversation has always been, now that we move past move past the common causes, adrenal, is it gonadal or is it exogenous? And I think my very simplistic analysis of this is to say that the DHEAS, which is an adrenal source, is normal. And so it prioritizes either an exogenous source of testosterone, which is now verified as abnormal, or a gonadal source of testosterone. And so the question for me is, as a non-expert, is should the DHES be suppressed in this instance? And therefore that normal is abnormal. And I don't know the answer to that. I don't know if the same endocrinological principles apply of normalcy here, because you can say, hey, this person has so many androgens on board. I know that. So is the DHEAS the source of the testosterone because it is not suppressed? Or do we not use do those principles which are theoretical not apply in this instance? The answer is I don't know. I have no idea. The negative TPO also caught my eye because we've diagnosed this patient with hypothyroidism, and the vast majority of patients with hypothyroidism have Hashimoto's thyroiditis, and the vast majority of patients with Hashimoto's thyroiditis has a positive TPO. So is this patient, as Thiago has taught us many times, have been misdiagnosed with hypothyroidism as a result of imperfect analysis of the TSH and T4 in the past? And I think that possibility is very strong and only supported by withdrawing the Synthroid and seeing if the hypothyroidism resolves. So I'll leave it at that for Thiago to teach us much more. But the ongoing questions are, does the endocrinological principles of feedback apply here? And the DHS is actually abnormal because it is normal in the face of elevated testosterone? Or is this an instance where we view the androgen axes as separate and view the DHS as normal and the source of testosterone being extragonadal? And I don't know. So with that, I will humbly sit here and learn and actually skim the chat to see if anyone else has thoughts on this. And I think after a quick skim, I'll just pass the mic to Thiago to tell us more and then teach us.
So I love this point, Rabbi, because in endocrinology we always think about the axis, as you said. So is it normal in this situation? And so I loved Travis' point in the chat. He asked, what regulates DHEAS? So that's the question. And do you know what regulates it? It's ACTH. It's ACTH. So yeah, for this reason, in congenital adrenal hyperplasia, you have hyperandrogenism because there is a defect in an enzyme and you cannot produce steroids, you cannot produce cortisol. Then it deviates towards androgen production. So ACTH is the point there. Yeah, so it's normal because if you expect ACTH to be normal, and I didn't order ACTH because I'm as you said, we are not thinking about a problem in this axis. So it's normal and normal. It's not related to testosterone. Testosterone does not regulate ACTH and does not regulate DHEAS. Good. And that being said, I ordered her a ultrasound, a transvaginal ultrasound, and the result was ovaries not seen, no mass. So I'll stop here a little.
So intriguing. So I think it's incredible to reflect on to reflect on how we think how a patient's gender is assigned. And I think that, you know, we've made an assumption based on the person's appearance that she's a female. And now when we don't see the ovaries, we have to wonder, like, what is this patient's gender? And I think that, you know, in society at large, we've done a poor job of understanding people's sex assigned at birth and gender identity. And that is a conversation that I think we really should give space to and a reflection on. But I will say that if you ever come across somebody who has a difference of their gender identity versus their sex assigned at birth, you'll learn a lot from talking to them about the harm that we've done as a society in not being understanding, flexible, and open-minded about how we impose things on people. And this conversation keeps coming up because I have a number of friends, family, whatnot, who also identify with the hirsutism as an incredibly stigmatizing thing. So we have a lot of things to reflect on here. So why would somebody not have ovaries? Oh, why would ovaries not be seen? I think it's because they're there and we're not seen, which I think is extremely unlikely. The other possibility is that they were there before and were removed, or they weren't there at all. And why wouldn't they be there at all? Well, one, you know, the sex assigned at birth was a female, which might have been incorrect, and the chromosomal makeup of this individual might be XY, but because of a chronic deficiency in androgens, have shown up as XX phenotypically. So where am I at now? I am speculating purely, and I would be what would be happening in real life is I would be sitting quietly, acknowledging the sheer humility and knowledge gap that I have in this.
Ravi,
yes,
I loved your comments, and I did not thought I have not thought about it, because the first time she went to my office, she was with her daughter, so I knew she was XX. But your thoughts were amazing, because yeah, that's completely true. It could be a XY with androgen resistance. Yeah, for sure. It could be great, amazing thought, because it's very important to address their problems in the society. I see patients who have transsexualism and they suffer a lot, and it's very important to discuss it. But I knew it wasn't the case because she was pregnant twice, actually. She had two children.
Wow. So, you know, I wouldn't know. So now we know she had ovaries before, so they're probably very small or were removed. She had a surgery to remove them. And so if she has had surgery to remove them, I'd start to speculate. Does this person have excessive testosterone, not because of an excessive production of testosterone, but a relative deficiency in estrogen as a result of oophorectomy, and whether the adipose tissue here corresponds to that excessive androgen generation. So I don't know. I really, what I want to do is I want to say, you know what? This is so incredibly interesting and complicated, and I'm so glad that it doesn't appear to be that this patient has a tumor in the ovaries producing this, but I would be at two places. Is there an extragonadal tumor that's producing testosterone? Or is the adipose tissue the source of the excess androgen in this situation? And I would be passing the mic to Tiago to take us home and teach us. And as I think we all were hoping for, a 15-minute masterclass of Tiago. So please take it away, my friend. Take us to the end and just all that you can.
No, it won't be. So can I, at this time, I thought, oh, there's something going on. So just to say, as you said, to solve the problem. So when you have a testosterone that is over 150 in a woman, you should expect a tumor. As you said, PCOS is not expected at this age, but if you have a woman who is 20 or 30, doesn't matter, and her testosterone is 373 as it was here, it's a tumor. You can you need to find the tumor. And so after seeing this ultrasound, I ordered a CT scan. So to look at the adrenals. So that was my goal, because, you know, when you have these testosterone, it generally mostly it comes from ovaries, but ovaries were not seen. So let's look to the adrenals, and it's not good because if you have an adrenal tumor which produce androgens, it should be malignant, and it's not good. It's not common for them to be benign. So I was worried. I was worried about her weight loss, and so I ordered a adrenal, a abdominal CT scan. Can I share my screen? Then I can show the image. Where are you? Here.
All right, you should be able to share the screen now, my friend.
So can you see the image?
Yes, we can. Wow.
Okay, so look, this is the bladder, this is the uterus, this is the ovary, the left one, and this is the right ovary. So can you see the tumor here?
Yeah, that looks massive.
Yeah, that was a very, it was an important lesson. So the tumor is clearly here. So after that, she went to the surgery. She was referred back to her gynecologist. The right ovary was resected, and it revealed a benign ovary steroidal cell tumor. So a tumor, a large cell tumor. Soon after surgery, her testosterone fell from 373. It was repeated, and it was 350 to 15 after the surgery. Months after the surgery, the coarse hairs appeared, the acne improved, and her voice softened. I suspended her contraceptive pill. It was not indicated. I have no idea why her gynecologist indicated. And I also suspended her levothyroxine because she did not have hypothyroidism. And her TSH continues to be normal right now. Her diabetes is under control, and it was under control at that time. And that's the case. I can comment a little bit about this tumor if you want me to talk about it.
Tiago, I'm always just so humbled whenever you present and learn so much for two reasons. One, I think you're just an outstanding presenter and educator, and I think everyone on the chat knows that. But also, I think that as an inpatient provider, my exposure to outpatient endocrine, like I would never make contact with this patient in my exposure in the inpatient side. And so you bringing the outpatient cases to us is just so helpful because most of VMR is inpatient, and this is just so educational. I actually have to run to work, so I'm going to put VMR on my phone. But I would love for you to just maybe share how you approach hirsutism in general, like how you just think about it as an endocrinologist, and then also, of course, teach us on this tumor. And then maybe after you teach us all that you always do, we'll pass the mic to Gerline to take us home for teaching points.
Great.
Is that okay?
Yeah, it's okay. Thank you. I'll just say a few words that, light cells, they are very rare and they are benign. So they correspond to 0.1% of all ovarian tumors and 15% of the steroidal cell tumors. They present in postmenopausal women, causing hyperandrogenism and virilization, as happened here. The symptoms are variable, and they include hirsutism, acne, voice changes, but also mammary gland atrophy, which he did not have, and virilization. So I would say that once you have a postmenopausal woman with a pheromone of over 8, then you should take a look in the testosterone. DHEAS, I don't know if that's correct to say in English, but you know what I mean. It's not a good predictor if the tumor is in the adrenal or in ovary, but this patient, once she had a testosterone over 150, I knew it was a tumor, and I was expecting to be in the ovaries, which is more common, and it's much better because they are generally they are benign. So it's not common to have large cell tumors, but you can have testotoxicose from ovaries. So it's very interesting because it's common for steroidal ovarian tumors to have a normal transvaginal ultrasound because these tumors can be small. It was not the case here. The tumor was not small, as I showed. So the ultrasonographist did not catch it. And it's an operator-dependent exam, so failures can happen. But these tumors can be small and undetected in ultrasounds. sometimes these tumors, they are not identified even in the surgery. So if I did not find anything wrong in the CT, I would refer her for a bilateral ovarectomy. So she would have both ovaries resected if I did not find what was going on, because if the adrenals were normal and you have a testosterone that is over 150, just take the ovaries out. And I think that the most, what I can help you here is that you should know that a high testosterone in a postmenopausal woman should raise suspicion for adrenal and ovarian tumors, and do not believe in serological markers. Look for tumors in ovary, ultrasound, transvaginal ultrasound, and if it's normal, abdominal CT scan. And as I said, a normal transvaginal ultrasound does not exclude testosterone producing ovarian tumors. And I'll pass it on to Gerlene.
Yeah, thank you so much, Thiago. This was a really interesting case, and I learned so much from the discussion. So you already had some amazing teaching points, so I'll just summarize some of the things that I took away from the case. So when we're thinking about hirsutism to begin with, we're thinking about, is this pathology or is this something that represents normal? So there might be a spectrum of normal based on ethnicity and other things that could affect. The other thing that's important is it hirsutism or is it hypertrichosis? So hypertrichosis is usually not driven by androgens because it's an increase in vellus hair. So why are androgens associated with hirsutism is that they increase the conversion of vellus hair to the terminal hair form. And that's why there might be some different causes based on the underlying pathophysiology. So when we're approaching hirsutism, the different categories to think about are familial causes, idiopathic. Obviously, idiopathic would be a diagnosis of exclusion. And then the other aspect we're thinking about is excess androgens. So are these excess androgens coming from an endogenous source or are they coming from an exogenous source? So when we're thinking endogenous, we're thinking about things such as Pcos, androgen secreting adrenal or ovarian tumors, Cushing's, congenital adrenal hyperplasia. And then when we're thinking about exogenous sources, this could be things such as anabolic steroids, but also certain medications. Robbie mentioned minoxidil, and other medications include phenytoin that could lead to hirsutism. And then overall, when we're approaching hirsutism, we're thinking about what hormones are involved in the endocrine axis. Is it androgens? Is it cortisol related to Cushing syndrome? Is this acromegaly? Is it obesity with an increase in estrogen leading to more conversion to androgens? Or is this a relative deficiency of estrogen and a relative increase in androgens that's causing the phenotype? So the clues that the next step was to kind of layer on the symptoms based on the other associated findings. So in this case, we specifically had signs of virilization. So we had acne, deepening of the voice. Other things would be clitoromegaly. And again, skin exam was really important because that helped us think less likely causes such as Cushing's. We didn't see any striae or other abnormalities. And then when we're thinking about diseases overall and clinical reasoning, thinking about the base rate of disease is really important. So we know that Pcos is the most common cause of hirsutism, but in this patient she's 51 years old, we were less concerned about that because Pcos usually manifests initially at a younger age. And then we learned from Robbie about the illness script for insulin receptor antibody syndrome, which occurs in patients with other autoimmune diseases leading to antibody formation and can have alternating hypoglycemia and hyperglycemia, along with hirsutism and acanthosis nigricans, which is basically a physical exam finding for insulin resistance. And then when we're thinking about adrenocortical carcinoma, overall, the suspicion is more likely in females that are middle-aged, 50 to 60 years of age. And overall, when we're thinking about endocrinology complaints, it's important to remember that sometimes normal lab values might not be normal based on feedback loops. But in this case, the DHEA being normal was actually normal because it's not regulated by testosterone, but it's regulated by ACTH. And I think the overall things that I thought were really important for the discussion is that when every diagnostic test has its limitations. So in this ultrasound, we didn't visualize the tumor, but the diagnostic suspicion was high based on the elevated testosterone in a middle-aged female. So it was important to follow up on that high diagnostic suspicion. And then as Robbie reflected, it's important to understand that as a society, sometimes we don't do well in terms of understanding patients' gender identity and how that might be different from the assigned sex at birth. So thank you so much, Thiago, for presenting. Thanks everyone for joining us today. Hope to see you soon.